But anyway, good morning and welcome to our final week. If you haven't been in here this season, we have 9 weeks of programming. This is the last week of the season. It's been a really great topic, exploring how we create healthy and livable communities. And we've had quite a few presentations. Hopefully you'll go to the ones that are taking on this week. My name is George Murphy. I serve Chautauqua Institution as their Chief Marketing Officer. Before we begin, I'd like to thank Dr. Hanson and LECOM for supporting us today. And as some of you may know, LECOM has supported us the last 3 years in this last week of the season when we were exploring healthy communities and options for healthy, more sustainable living. So they've been a really big advocate for us. I'd also like to welcome the LifeWorks Erie's crowd that came in today. I know you think you've come 3 years now, so thank you so much. Good luck with your map. And all I can tell you is you have to be back here at 4:45. So if we see any stragglers, I think we'll know who they are. Dr. Danielle Hanson is a graduate of the Lake Erie College of Osteopathic Medicine. She is board certified in internal medicine and geriatrics and currently the assistant professor of internal medicine at LECOM and vice president of acute care services at Mill Creek Community Hospital. Dr. Hanson has been directly involved in the development of geriatric services for the new LECOM Senior Living Center, a 138-bed skilled nursing home. As most of you know, at the end of Dr. Hanson's presentation, we love to take your questions. So there's a mic on the lower level here, and there's one up top. So those are free for you when she finishes her presentation. Today's topic is accessing care for complex medical issues. So please welcome Dr. Hanson.
Thank you. Good morning, everyone. It's very nice to be here this morning. Glad to see all of your bright and wide awake, smiling faces ready to learn. I'm going to go through the presentation, and as I go through the presentation, if you have questions along the way, feel free to raise your hand. Otherwise, we can field them all at the end, which may be easier with the microphones, but I don't want you to lose track of any of those questions or ideas that the content might spur. So the things we're going to talk about this morning, we're going to talk about aging demographics. We're going to talk about limitations of clinical practice guidelines, especially for our older adults. We're also going to talk about the approach to older adults with multiple medical problems. I'm going to define that word there, multimorbidity. We're going to talk about challenges for caring for those patients, as well as coverage for healthcare expenses for older Americans, the challenges associated with that, as well as some of the really great new initiatives and innovations that have come into fruition in the last couple of years. So as everyone knows, the number of older people is increasing. It's increasing because the baby boomer generation is getting older, as well as we're living longer and healthier. So by 2030, it's estimated that 1 in 5 Americans will be a senior. That's about twice the number that we had in the year 2000. And our life expectancy is increasing as well. So by 2050, the life expectancy for women will be up to 86 and 80 for men. Women still will be outliving men. At least that's what the estimation is. And there's multiple reasons for that. Last year I talked about women's health, and we talked about that quite a bit. Healthcare utilization. So as we have an increased number of older people, we also have an increased amount of healthcare that needs to be paid for, needs to be accessible, and needs to be available for our patients as they need it. So 50% of doctor's visits are from those people who are over the age of 65. 30% of prescription medications, 90% of long-term care beds, so that would be nursing home, assisted living, or custodial care, and 50% of hospital beds. And that's probably not a surprise. We expect as we get older, we have more medical problems, and we need increased care than our younger counterparts. When we ask people how they feel about their health, do they feel that they're healthy and well, or do they feel that they're sick and frail? Here's the numbers by age group, then the difference between men and women. So men between the ages of 65 to 74, about 19% of them felt that their health was poor, but by the time they're over the age of 85, that number increases to almost 32%. For women, it's a little bit less, 17% to almost 30%. Some of you may be a little bit surprised by that because sometimes men are less likely to seek medical care, less likely to be forthcoming with how they feel about their medical care, by sort of stereotype, I guess. But actually, they do report that they perceive their health as poor. And a lot of that is because we have a lot of chronic conditions that increase in number and severity as we get older. This graph shows that the number of people over the age of 65 with high blood pressure is 60%. So that's a high number. Over half of people over the age of 65 will have high blood pressure. Arthritis is 50%. Heart disease, 30%, cancer, diabetes are both in the 20s, and stroke is 10%. Certainly in research and new medications that are coming out, what you see on the TV and read in newspapers, there's a lot of focus on treatment and further research for discovery related to cancer. There's a lot of new medications coming out for diabetes, but high blood pressure and arthritis aren't really focused on nearly as much. There are some medication options, obviously, for both of those. There's a lot of medication options for high blood pressure, but it doesn't get nearly as much notoriety or press as some of the other diseases, even though the prevalence is much, much higher. If we look at the average age of onset for some of those common diseases, you can see that the majority of them begin after the age of 50 and then significantly more after the age of 65. So multimorbidity is defined as when someone has 3 or more chronic diseases. And 2/3 of people over the age of 65 actually have chronic diseases and meet that definition. So multimorbidity, it's not a common term, I think, but it's probably going to be growing in usage in the future. And there's some distinct characteristics associated with it. Everybody is affected by those different diseases in a different way, but we know that people who have 3 or more diseases have a higher risk of death, certainly, higher risk of disability, so they're not able to function as well, live in the same home environment as they had in the past. And there's a lot of adverse effects either from the medications that are treating those diseases, interacting with each other, or interacting with one of the other diseases, or one disease and another disease sort of interacting with each other. A lot of institutionalization. So not only are these patients more likely to be hospitalized for an exacerbation of one of those diseases or an acute illness that may be more likely to set in because they have lots of medical problems, but they're also more likely to need nursing home care, assisted living care, custodial care. And certainly we're using a lot of our healthcare resources to provide care for these patients. And the goal is to really maintain the quality of life as best as possible. But certainly as we have more diseases and illnesses, as we would expect, there is impaired quality of life or certainly a big impact on that. Now, to treat those patients, we have to be very cautious because the different disease processes can interfere with one another, or to treat one disease, you might make another disease worse. For example, if somebody has congestive heart failure, the medication we use to treat congestive heart failure to make the heart pump more efficiently can cause problems with the kidneys. So, but if the kidneys don't get enough blood flow because the heart's not pumping efficiently, they can have problems in and of themselves. So it's sort of a balancing act between the treatment as well as the different diseases. And they all affect everybody differently. So when you look at one patient with high blood pressure, high cholesterol, diabetes, and heart disease compared to another patient, even if they're in the same age group, same gender, how those diseases affect them is going to be different, and how we treat them is going to be different. They'll be on different medications. Their functional life or the things they do on an average day will be different because they interact very differently. And that makes it challenging, I think, for us as healthcare professionals to treat those patients ideally, because it's not as cookie cutter as some of the other medical specialties, or for our younger patients with maybe only one medical problem that doesn't have a big impact on their life. And when we choose our treatment, what we look for is, what do the guidelines tell us? So there's clinical practice guidelines pretty much for almost every disease process where a group of experts have analyzed all of the research that's been done. Sometimes it looks at over 100 or over 150 different research studies that have been done on how best to treat different diseases, takes all that information and comes up with guidelines and recommendations for us as healthcare professionals for how we should treat our patients. But it's very hard to apply those guidelines to our patients who have multiple different medical problems. And one of the reasons is because the guidelines only look at one disease at a time. And the other reason is the studies that they're analyzing usually exclude older patients. So they exclude patients with other disease processes. And then they oftentimes exclude people over the age of 75 and sometimes even over the age of 65. So it's hard to apply what's supposed to be standard of care guideline treatment to all of our patients. So guidelines might be impractical, they might be irrelevant, and even harmful for our patients because they don't consider their unique features and characteristics. So when geriatricians, when we approach our patients, the things we need to take into consideration are patient preference. We need to interpret the evidence. We need to look at the guidelines, but it's not going to necessarily dictate what we do. But it is a reference tool, and it is something that we need to consider. We also need to look at the prognosis for whatever that disease is we're treating, as well as big picture prognosis for the patient in general when we look at all of their comorbidities together. And we also need to consider clinical feasibility. If somebody is supposed to have a bone density test based on their age and their gender and their risk factors, but they're in a wheelchair and it's very difficult to get them out of the wheelchair onto an exam table to do that bone density test, maybe it's not really clinically feasible for that patient to have the test done. So we need to consider that. And we also need to optimize our therapy and care plans. We'll go into each of those in a little more detail. So patient preference, this is really the most important thing. I think it's our job as healthcare providers to educate our patients, present them with information. What does the research show? What do the guidelines show? What are the recommendations? And then it's really up to the patient to take that information, ask whatever questions they have so they can have a thorough understanding, and then choose what treatment approach they want that fits within their own preferences, within their own value system, within their own cultural system. And that can be very different from one patient to another. So we really need to make sure that we're paying attention and involving our patients in their care. Some patients don't want to make the decision. They want to be told what's best for them, and we're happy to do that as well. But other patients don't want to be told what's best, and they just want to make the decision. So it's still our job on either of those extremes to educate the patient and involve them in their care decision. And older adults with multiple medical problems, even more so, need to prioritize their preferences for care because it makes it more complicated and complex to choose their treatment plan and approach. When we look at the evidence, like I said, a lot of research doesn't involve older patients. A lot of research doesn't involve older patients with multiple medical problems. So we have to interpret that information very cautiously when we're taking that information and applying it to the patient sitting in front of you, or your friend or your family member. We really need to be cautious with that to make sure that it's appropriate. There is significant gaps, and hopefully in the future, as we continue to have more older adults with multiple medical problems living longer, living healthier lives, they will be involved in much more of the research and will have better guidelines and evidence in the future. In terms of prognosis, it's very hard. None of us have a crystal ball. We can give prognostication information based on history, based on some of the literature that's available, but again, it might not apply to every patient. Something that I find is helpful, especially in patients who have memory impairment and their Alzheimer's disease or their other form of dementia is progressing. Families want to know, patients want to know how to prepare for the future and how quickly they're going to have to enlist other resources or maybe change, where that family member's living, those kinds of things. So something that I think is very helpful to do is to look at the last 6 months. Look at how the disease has progressed in the last 6 months, and you can expect that the next 6 months next 6 weeks, are going to progress in a similar fashion. So if you've seen very little change over the last 6 months, even couple of years, you would expect very little change unless there's, an accident or an illness that may contribute. But if you've seen rapid progression over the last 6 months, maybe someone's, now they're incontinent, maybe they're not able to dress themselves anymore, then you would expect that the next 6 months or even shorter than that are going to progress at a similar rapid speed, and you would change your treatment plan, enlist some additional resources based on that information. And it's difficult, we certainly don't know. We have all these numbers for how long we expect people to live, how long people with certain cancers, for example, survive. But every patient is different. And even with that information, we certainly have no guarantees. We're very cautious. Physicians tend to be very cautious to give any of that kind of information because we don't want to be wrong. We don't like to be wrong at all, no matter what, but we certainly don't want to be wrong about that. And we don't want someone to feel as though, or us to feel as though we didn't meet, if we said, you'll have 6 months to live kind of thing. We wouldn't want to feel like a disappointment or we failed if we didn't get to that time frame. So physicians really hesitate, I think, to provide that type of information, though it is certainly available and your doctor can give it to you if you press them. So feasibility, I talked a little bit about like the DEXA scan patient. If you have someone who needs to have a screening test, or it's recommended to have a screening test, and it's not possible for them to position appropriately for that diagnostic test, then certainly you're not going to be able to do that. So you have to look at the complexity of the screening test or whatever the treatment option would be, as well as the patient's existing state. How functional are they? What are their comorbidities? What are their goals for care? It's taking those patient preferences into consideration as well. Something else to consider when we're putting patients on medications, if for high blood pressure, for example, there's a number of different medications, probably 20, 30 different medications we can use. Some of them have to be given every 6 hours or every 8 hours, and other ones are only given once a day. So it's obviously much easier for a patient and for a caregiver to give a medication once a day rather than 4 times a day, trying to make sure they're getting it spaced out appropriately. So we need to take in consideration how complex we're making the treatment plan, because if we're making it too hard, no one's going to be able to follow it, and then we're not going to get the results that we're looking for. And certainly adverse reactions related to medication use or to using medications inappropriately can occur. A lot of patients don't take their medications at the right time of day, or they don't take them with food if they're supposed to, those kinds of things. So we need to make sure we're asking those questions of our care providers so that you're getting the maximum benefit out of all of your medication. All right. In terms of optimizing our therapies and care plans, we want to choose things that minimize harm, obviously, enhance quality of life, and we want to optimize the benefits. So we want to do everything to optimize the health of our patients, but we don't want to do that at the expense of causing a side effect, causing an additional problem, or impairing the quality of life. So we want to make sure everybody's able to enjoy their interactions with their family members, enjoy the activities they like to do. Those kinds of things is much more important than having another week or another year. Unless that's the patient's preference, if they prefer time over quality. But usually people want to spend time with their family members, their friends. They want to enjoy their hobbies. They want to do those kinds of things. So we want to do what we can as healthcare providers, and you want to ask those questions of your healthcare provider when you're determining treatment plans. All right. So there's a lot of challenges associated with taking care of older patients with multiple medical conditions. And some of it are the things we discussed. Additionally, patients who have multiple medical conditions don't always stay stable. There's different things that can tip them off if they're walking the tightrope. There's different things that can tip them out of balance that we need to respond to or address. And patients may not be able to recover from even minor colds or flus or things like that as they could when they were younger, or if they didn't have as many medical problems. So we need to be alert to different signs and symptoms that might occur. We need to make sure that we don't ignore them. We need to bring them to our healthcare provider's attention if something's not feeling quite right, because it might be a symptom of something that's very important or a problem related to one of our other treatment regimens. And there's also oftentimes people with lots of medical problems see lots of different doctors or healthcare providers, and different doctors are adjusting different medications. And sometimes that information doesn't get passed from one healthcare provider to another very quickly or very efficiently, I guess, and clearly. So we rely on the patients to bring into us any new medications or changes that they've undergone by another doctor. We also want to get those reports. And when you work with a physician who works in a health system, oftentimes they share an electronic health record and have access to the other physician's documentation and what their treatment plan was. But it is still a challenge. We shouldn't have to rely on patients to come forward with that information. Us healthcare providers should be able to get that communication piece down. But right now, it's not smooth across the entire country. So it is something that we really do need to have an active role in as patients and caregivers. Additionally, a lot of times we have to make a decision that's going to affect us in a lot of different ways. You know, if you choose, option A, it might make something else worse. It might make something else better. So there's a lot of different things that go into decision making in taking care of patients. I talked about how the current evidence or literature is not sufficient to meet all of our needs. And we don't have all of the prognostic information that combines different disease processes. We have good prognostic information that talks about one disease, but it doesn't talk about that disease in a patient who has 3 others. Treatments might actually make things worse. And sometimes our treatment plans are too hard for people to follow. There's another thing that weighs into physicians' recommendations for treatment as well, and that's we don't want to cause someone to have a bad outcome. Most doctors, I would say pretty much everybody who goes into healthcare does it because they want to help people. We want to make people better. So we're fearful of having something not work out as planned, even though we know that with a lot of treatments there's an inherent risk. We don't want to be on that small percentage where our patients didn't have a good outcome. So that's something that we fear, and it's something that you need to be aware of when you're involved in making treatment decisions as well. So something else that's a factor is really our coverage for healthcare expenses in terms of insurance coverage, Medicare coverage, and other financial resources, and how we can meet the needs of our older patients who are continuing to age, have multiple medical problems, and how those are all affecting their functional life. So I'm going to talk about Medicare primarily, a little bit about Medicaid, Medigap insurance, and the Medicare Advantage program. And I'm probably a lot of you are familiar with some of this information, maybe even all of the information, but hopefully I'll be able to provide a little bit of insight, and some of it from the provider or from like the hospital or healthcare system administrative perspective that patients may not always realize are some of the challenges we face in getting you the care that you need. And we'll talk about it by using a case example. But first, we're going to go over some Medicare Basics. So basically, a Medicare federal insurance program run by the Centers of Medicare and Medicaid Services under the Department of Health and Human Services pays for acute health care provided for Americans who are over the age of 65, for those who are disabled, or for those who have end-stage renal disease. Of all the people receiving Medicare, there's only about 10% or so that are not over the age of 65. So that disabled category or end-stage renal disease younger than 65 is a really small percentage of everyone that receives Medicare. And then we have the different types of Medicare. So there's Part A, B, C, and D that we're going to talk about. And it was originally created in the 60s, but has evolved since then, certainly has evolved. 97% of our older Americans are covered by Part A and B. So 3% are not. Some of those 3% may have VA benefits, for example, but there are some patients that only have Part A and don't have any Part B benefits, which could be a financial strain for any of the services covered by Part B. This is sort of an umbrella and diagram to show you what's covered where. So Part A is the hospital coverage, essentially. So hospital services, skilled nursing services, home health care, and hospice are under Part A. Part B is the physician coverage. So if somebody only has Part A, maybe they're not sick very much, maybe they don't go to the doctor because they choose not to, but they have an illness that they need to be hospitalized for. Their hospital bill will be covered by Part A, but none of the doctors seeing them in the hospital would be paid for because they don't have Part B, and that would be billed to the patient. So it could be a significant financial strain, even if it's someone who thinks they're healthy or never wants to go see a doctor. I doubt that there's any of you in the room that fit that category, that doesn't like to see a doctor or refuses to, because otherwise you wouldn't be here today to learn about being healthy and living in a healthful community. But Part B does cover those physician expenses. It covers outpatient care, some home health services, and some preventative services. Part C, that's the Medicare Advantage program. So that covers everything that's in A and B. It's just managed by an insurance company rather than managed by the federal government. Federal government gives the insurance companies money to administer those programs. And some of those plans, most of them, have drug benefits. And then Part D is the prescription drug benefit for medications that are self-administered. So if somebody needs a medication that is IV and administered, for example, there's a medication that is used to treat osteoporosis that's given IV once a year, and that's administered usually in a hospital setting or an infusion setting. It takes about 30 minutes. That is not covered under Part D. That's covered under Part B. So for people who have a need for treatment for osteoporosis and have a difficult time stretching those Medicare Part D dollars, it can be advantageous to use one of the other treatment options with a different delivery route so that the medication goes under those Part B services that doesn't have a cap like the Part D does. This is a schematic of where the dollars, Medicare dollars went. 2012 was the most recent I could find. But you can see 21% were hospital inpatient services, 19% were to the Medicare Advantage program, where the federal government gives those insurance companies money to administer their programs, and an additional 19% was for prescription drugs. So those are the big numbers, the highest areas of utilization. Medicare Part A, it covers that hospital, the skilled nursing, home health, and hospice. Older people or those with spouses who've had paid into the Medicare system for at least 10 years qualify for Medicare Part A. Sometimes we do have patients who haven't worked. Maybe they haven't worked outside the home and have not paid into the system for 10 years. So they have other options from the Medicaid side of things to cover their healthcare needs, and they wouldn't qualify for Medicare. Others might be able to purchase it, but usually those people may not have the funds to do so and oftentimes qualify for Medicaid. There is the deductible for Part A, $1,260 per benefit period. Each benefit period is the 60 days related to a spell of illness. So the first 60 days, there's no coinsurance. From 61 to 90 days, $315 coinsurance per day, which is a lot if you're using all of those days in there. And then days 91 and beyond, a $630 per day fee. Up until 60 of the lifetime reserve days are used. For people who use all of their lifetime reserve days up, then they're responsible for all costs. And those lifetime reserve days don't reset, ever. So, these patients, when you're looking at this number of hospital days or skilled nursing days, that's a large number of days. But unfortunately, some people do fit that category and use up all of their lifetime reserve days. So then they're billed for their care themselves, or if they qualify for Medicaid or have a supplement, they would potentially pick things up for them. But these are more often people who have like a catastrophic accident, are in the hospital for quite some time, recovering from that accident, multiple surgical procedures, those kinds of things. Or for people who have a chronic illness that lends it to representing to the hospital on a fairly frequent basis. Sometimes patients with mental health issues that aren't well controlled do go into their lifetime reserve days as well, or you use them all up. For Medicare Part B, so that's the physician expense, social worker, psychologist, therapies, therapists, labs. Durable medical equipment comes under Part B. Durable medical equipment, that includes walkers, wheelchairs, canes, things of that nature. It also includes diabetic shoes, bandages, dressing supplies, those kinds of things. Again, if you're eligible for Part A, then you're also eligible for Part B, but you have to pay your monthly premium, and there is an annual deductible and a 20% co-insurance for many of the items that are included in coverage for Part B. For Part C, so these are the Medicare Advantage programs. So this is Security Blue, Freedom Blue, Health America has a program, Aetna has a program for our local folks. Those are the probably bigger insurers in the region, UPMC. They all have a Medicare Advantage plan. So again, the federal government gives the insurance company dollars so that they can administer their program. They're required to follow at least the minimum coverage of Medicare, and sometimes they offer additional things to be covered. So for example, some of those programs may cover glasses or eye exams, whereas traditional Medicare does not, unless there's a disease-related process such as diabetes. So some of the Medicare Advantage plans do offer additional benefits. The premiums and out-of-pocket expenses are individualized per program, and usually you can choose how much you want to pay, and then your co-insurance it varies based on how much you pay for your premium. Part D is the prescription coverage. And people who are eligible for Part A and B are eligible for Part D. You have to sign up for it, and the cost varies by your plan. Your generic and your prescription copay varies based on your plan. There is a website that you can go to. You can put in all of the medications that you take, and it'll spit out which plan gives you the best coverage for you. So that's a good tool to utilize, especially if you're someone who's fairly stable on your medication regimen. The donut hole related to Part D. As part of the Affordable Care Act, they've made a lot of changes for the donut hole to decrease the amount of responsibility on the patient related to the brand as well as generic drugs. So by 2020, it's going to be 25% responsibility for the patient for both, whereas you can see in 2015, it's 45% for brand name and 65% for generic that is covered. So it'll change down to 25% by the year 2020, which is something very positive. And the total dollar amount for the donut hole to use increases pretty much every year. $4,700 this year, $4,850 for 2016. So hopefully that will allow patients to continue their medications throughout the entire year, not have to kind of pick and choose what to do or substitute things to try and stretch the dollars a little bit longer, or incur a significant individual expense. Medigap insurance. Medigap insurance is for people who are on Part A and Part B deductibles and their co-insurance costs. That's kind of what it covers. So that 20% copay or some of the other patient responsibility can be covered by Medigap insurance. A lot of different private insurances offer this as well. So this ends up being that secondary insurance. Pretty much pays the balance for most things that Medicare will cover. But there's a little bit of difference by plan type as well as geography, and a little bit of difference in terms of premium and what your rate would be as well. Medicaid, so that is for patients who have to qualify based on income. So for patients who have a lower income and aren't able to afford a Medigap insurance plan, don't want the Medicare Advantage or can't afford Medicare Advantage, they may be able to qualify for Medicaid to pick up that 20% or the difference that Medicare does not cover. They do cover a lot of other expenses as well, and some of the drug benefits are very, very beneficial for people who qualify too. In Pennsylvania, I'm obviously more familiar with Pennsylvania rules and insurances, and there's different ones to choose from. There's very limited use of just plain state Medicaid anymore because of the insurance marketplace as part of the Affordable Care Act and the changes that went along with that. But most of them offer a lot of benefit for patients in terms of being able to access their medications and having limited or very little out-of-pocket expenses. The covered preventative services have also improved or increased since the Affordable Care Act went into effect. So here's a list of things that are covered. Not everything is covered, but there are a lot of things that are covered and promoted. to be done on a with whatever frequency. So checking for cholesterol, colon cancer, mammograms, all of those things covered by Medicare from the preventative side, as well as the Welcome to Medicare exam and an annual wellness visit. So the Welcome to Medicare exam has to be done within the first 6 months of becoming a Medicare recipient, and then the annual wellness exam is done on an annual basis thereafter. And the focus of that visit is to talk about preventative services, to come up with a treatment plan to try to decrease impaired quality of life, to try to decrease falls, to try to decrease depression, those kinds of things. Make sure that we're identifying any diseases that might be occurring that would be new, and to come up with a appropriate treatment plan in terms of lifestyle, nutrition, exercise, that sort of thing. So that's something that came about, was pushed more so in 2011 moving forward, but we're still less than 50% of patients having them done on an annual basis. When I say we, that's like the entire country. Non-covered services, hearing and vision services and dental care is probably one of the most frustrating things that I hear from patients. It's very important for people to be able to see well. It's very important for them to be able to hear, yet unfortunately those are non-covered services by Medicare. Nursing home care as well, and we'll talk about that as we go through a case. From the physician participation standpoint, physicians have to opt into Medicare or opt out of Medicare. Those who choose not to participate in Medicare usually have that concierge model where a patient will pay them a flat fee to be their doctor, and then they're supposed to provide whatever services that patient needs, and they do not bill insurance or Medicare for those services. That's really about less than 1% of all physicians. Most physicians participate in Medicare. All right, so here's the case we're going to go through. We have Mrs. M. She's a 79-year-old retiree. She lives at home with her 83-year-old husband. She has a few medical problems, but not too many. She's on 4 different medications. She is very good about seeing her doctor regularly, having her preventative services done, and she gets an annual wellness exam. And she's trying to decide if she should continue with regular fee-for-service traditional Medicare or if she should consider a Medicare Advantage plan. So the options are to stay with or to get a Medigap insurance, I guess would be the third option. So really, it's up to the individual patient based on their current condition, but you can't predict the future. So you don't know what needs you're going to have in the future, which makes it a little bit challenging to make those good decisions. But the other thing to think about, in addition to medical conditions, is your doctor. If your doctor does not participate in the Medicare Advantage plan network, then you would have to pay a higher rate to see that doctor, or you would have to switch to a different primary care physician. So the Medicare Advantage plans, especially in our region, are rather competitive with which doctors are in network with different programs. So that's something that you would want to consider when you're trying to choose which plan or which route to go. There is a Medicare personal plan finder available on the Medicare.gov website. So it gives you information about different rates, different diseases, different medications, helps you to narrow your decision-making process, and it can be very helpful for those who are trying to make that determination. All right, so back to Mrs. M. So 4 months later, she awakens and she has symptoms of a stroke. So she goes to the emergency room by an ambulance, and the physician that is in the hospital that's assigned there diagnoses her with a stroke and admits her to the hospital. So while she's in the hospital, if she had traditional Medicare, she would be required to pay her deductible, under Part B for the ambulance and the emergency care. And then she would have her $1,260 for Part A for the hospital admission. The rest of her hospital admission would be lumped together in a diagnosis-related group is how the hospital is paid. Basically, it's taking the average patient with a stroke, similar to this patient, and how much expenses are normally associated with that, and that's how much the hospital gets paid, regardless of how many days she's there, regardless of how many resources she actually utilizes. The hospital just gets a lump sum, and they have to use that to provide for all the care. Co-insurance for this patient would be 20% for the physician fees in the ambulance, and then any ambulance charges excessive of Medicare's approved fee schedule the patient would be responsible for. Most of the ambulances try to follow the Medicare fee schedule, so that's not an issue. If she had a Medicare Advantage plan, then most of those things would be covered. One of the concerns would be, is the hospital facility in network with her plan? If not, they may want to transfer her to another facility, or she would be responsible for out-of-network costs associated with that. Something else to consider or to be aware of, I guess, when patients end up going to the hospital, and this is something that has increased in the last year, maybe year and a half, is observation status. When patients are admitted to the hospital as an inpatient, it's billed under Medicare Part A, but if they're observation status, then it's considered outpatient, even though they may be physically located within the hospital, and it's billed under Part B. So Part B, the patient expense is obviously much higher because you're responsible for that 20%, whereas Part A, there's just the deductible and that's it, and you're done. So for patients who are in the hospital, regardless of where they're located, they could be considered an inpatient or they could be considered observation. In the state of Pennsylvania, there's a law that went into effect last fall saying that we have to notify patients when they're in observation status so that they're aware of that. And there's been controversy from the federal level, and it's got pushed back to January of 16 for all states to have to provide that notification to patients that they're under observation status. There's not a lot that you can do about it if you're under observation status, except you have to be aware of the financial burden that will likely come to the patient rather than Medicare paying the hospital those expenses associated with your care. Hospitals don't like it. Patients don't like it. It's really not beneficial for anyone other than Medicare is paying less money for the same services delivered in the hospital setting. So, our patient, after she was stabilized in the hospital, she's ready for hospital discharge, but she's not quite ready to go back home. So we have to figure out what would be the best option for her rather than going directly back to home. So she needs some continued therapy. So we're going to talk about the different types of settings. Something else about this patient. So it says in this case, after 4 days, she's ready to leave the hospital. So like I said, the hospital from Part A for traditional Medicare is reimbursed a DRG, a diagnosis-related group associated with that care. If the patient is discharged sooner than the average length of stay, the hospital's payment gets reduced by a certain percent. So for a stroke, the average length of stay is 5.9 days. So if the patient leaves on day 4, the hospital is going to get paid less. But the opposite doesn't work. If the patient's not well enough to leave on 5.9 days and stays for 7, 8, 9 days, the hospital doesn't get paid more. So that's just something else that the hospitals are struggling with. Doesn't affect the patient necessarily, but it is something that the hospital struggles with in managing patients. We always want to do what's best for the patient clinically, but certainly have to be able to continue providing that care for them. All right, so after the patient leaves the hospital, what type of setting could they go to? If they have Medicare fee-for-service, traditional Medicare, Part A pays for 100% of 20 days in a skilled nursing facility and then 80% thereafter. Part A would pay for acute inpatient rehab unit. The difference between those types of units, an inpatient rehab unit delivers 3 hours of therapy 5 days a week, whereas a typical skilled nursing facility delivers 1 to 1.5 hours of therapy most days of the week. There's more intense medical supervision in the acute inpatient rehab unit. However, from the acute inpatient rehab unit, they have to have certain diagnoses to qualify to go there. Stroke is one of them, but a lot of other reasons that people are in the hospital do not actually qualify for them to go to that unit. So from a financial standpoint, there's shorter length of stay, there's more intense therapy, there's less expense for the patient in the inpatient rehab unit. However, less patients are eligible based on diagnosis according to Medicare rules. 60% of the people that go to those units have to have one of their 13 approved diagnoses. Part B will pay 80% of the physician fees. Pretty much that happens everywhere. From the managed care standpoint, we have to get an authorization for the patient to go to a skilled nursing facility. We'd also have to get an authorization for them to go to the acute inpatient rehab unit. They're not very likely to authorize the acute inpatient rehab unit, even for a stroke patient that Medicare, traditional Medicare would pay for. Much harder to get it approved. And then the physician fees and whatnot are also covered by the managed Medicare Advantage plan. Some people have long-term care insurance. More than 3 million Americans currently, that's what it's approximated at, have long-term care insurance. But these policies actually pay for less than 2% of all nursing home care. The majority of nursing home care is provided by medical assistance, Medicaid programs across the country. There we'll probably see more use of long-term care insurance in the future. And some of the policies cover other things besides nursing home care. They can cover home health care and other, sometimes DME, other types of services. It depends on the individual plan. So after this patient completed her rehab course, she did much better and she was ready to go home. So when she went home, oftentimes we recommend patients transition to home with some additional support in addition to the family. So she was recommended to have home health care services. And this can happen either because the patient's well enough and ready to go home, but also can happen because they've plateaued. So if they're not making progress anymore, either in the inpatient rehab unit or in the skilled nursing facility, they're going to get cut from therapy services. And then you have to make a decision. Do they go home with assistance or do they stay there and then the payment strategy changes because they're no longer considered skilled, no longer making progress towards their treatment goals? In terms of home health, Medicare Part A and Medicare Advantage both pay for home health. They pay that home health agency a fixed amount of money, and they have to determine how they're going to use it to provide the appropriate services for the patient. So it doesn't matter how many disciplines of therapy are coming into your home, how often the nurse is coming, that company still only gets one lump sum of money. For a nursing home, so if, for example, this patient either wasn't able to go home with home health services or something happened and her family wasn't able to provide assistance for her at home and she needed to be in a nursing home, no longer qualifies for skilled services because she had plateaued or she exhausted her skilled service benefits, then she would have to go to a nursing home and the payment structure changes where the patient is responsible for it unless they have a secondary or if they have medical assistance. So there is a nursing home compare website where you can compare quality and outcomes and things from nursing homes to help guide your choices. In all of those websites, there's a hospital one as well, and physicians. Usually the data, it'll tell you when the data is gathered from. Usually it's about 2 to 3 years old, so just use that as a caution when you're looking at them. Part B and Medicare Advantage plan pay 80% of the physician charges, but nothing covers the nursing home stay itself when they're no longer skilled. Average nursing home, about $200 a day, so $73,000 per year if, unfortunately, that's what somebody needs. Hospice care. Hospice care is covered. So if this patient had a turn of events that she required, or in the family and the patient opted for palliative care, hospice, and no further life-prolonging interventions, then she would qualify for hospice. In order to qualify for hospice, again, there's a set number of diagnoses, and the prognosis has to be if the disease takes its normal progression, that you would expect the person to live no longer than 6 months. Part A pays for hospice, and again, the hospice gets a lump sum money from Medicare, and they have to use that fund or that amount of money to provide the appropriate care for the patient. Now, they'll only provide care related to the hospice diagnosis. So our patients with multiple medical conditions, say they're on hospice for lung cancer, but they also have diabetes, their blood sugar checks, their machine, their insulin is not going to be covered by hospice, only the medications related to their hospice diagnosis and treatment related to the hospice diagnosis. This is where all the money comes from. Most of it comes from us, the individual Americans, over time, and then it gets distributed throughout the system. So Medicare and the government and everybody really are trying to increase the funds available to take good care of the patients, as well as promote the quality of care that we're providing for patients. So there's a lot of effort to fight fraud, scams, and waste, especially waste that's potentially going on in the country, I guess, to try and make those resources more readily available for patients that need them. So in doing that, there's incentive and penalty programs. The Medicare Advantage plan, so those insurance companies that are administering your Medicare program, they have a pay-for-performance aspect, and they receive bonuses if they're a 3 or higher on their star rating, and their star rating is based on how many of their patients are getting preventative services, how many of their patients are being readmitted to the hospital, a number of different things. So those insurance plans, in turn, flip that onto the doctors, and they score the doctors. So all the doctors have a scorecard from each individual insurance company where the doctors get a star rating to try and encourage all of us to provide the best care for the patients, certainly, but also they're trying to maximize the dollars they can spend to provide the right kind of care that our patients need. There's also been changes to the amount of funds that can go towards administrative expenses for Medicare Advantage plans, and there's been changes in the amount that need to be used for direct care as results of the Affordable Care Act. These are the domains that go into the 5-star rating. The biggest, with the highest weight or the highest number of measures is really the preventative services for patients. Hospitals have several different, mostly penalty programs. They initially started out as incentive programs, and now they've transitioned to penalty programs because they've been in existence for a couple of years. A value-based purchasing takes together the patient experience of care or patient satisfaction, as well as some of our outcomes in terms of mortality, readmissions, as well as are the patients getting the right medicine at the right time kind of measures. And they take money from all of the hospitals. This year it's 1.5%. And then at the end of the year, they look at how the hospitals perform, and the ones that do well get money back, and the ones that don't do well don't get any money back. So it's really a self-funded program where they're redistributing money. The hospital readmission reduction program, that's for patients readmitted to the hospital within 30 days for certain disease processes. Initially, the penalty was 1%. It's up to 3% for 2015. And then the hospital acquired condition reduction program. That's the worst performing. 25% of hospitals have a 1% penalty. And those 1%, 2%, 3% penalties, if you add them all up for one individual hospital and take that out of all of their Medicare reimbursement they receive, it could add up to something significant that may, inhibit their ability to hire additional staff, have more modern, up-to-date equipment, and things like that. So it's really helping to motivate hospitals to work hard. They've always worked hard to try and do the best thing for patients. But it's made them work harder, I think. And then the bar keeps raising because as everybody keeps doing better, that threshold to reach to not be penalized keeps getting further away. They're harder to reach. There's other things. The Center for Medicare and Medicaid Innovation, the Innovation Center, has been developed to try to look at other payment innovations, I guess, and different payment modalities or methodologies to try and increase the outcomes and quality of care delivered. So most of these have been done as demonstration projects throughout the country, and they're still working on different models of care to see what would potentially be the best for patients. There is an effort to tie 90% of reimbursement by 2018 to quality and not to quantity. So everybody used to just get paid for the number of patients they saw, regardless of how well their patients were taken care of or how well their patients' outcomes matched up. But by 2018, 90% of things will really be paid by quality measures rather than quantity or volume. So, in summary, before I take questions, certainly we have an aging America. That's not news to anyone. We need to make sure that we are engaged in our own healthcare choices. We're engaged in our treatment plans. We're involved in trying to stay healthy and be active and modify our comorbidities so that we can be as healthy and active as long as possible. There's a lot of patients with lots of multiple medical problems. We can't look at them as one patient with 3 different things. It's really 3 different, it's everybody together, or all those combination of medical conditions together rather than looking at each of them separately. So when we're using healthcare resources, when we're using and determining treatment plans, we need to consider all of that. Our payment system is rather complex. It's going to get more complex, and it's hard to keep track of all of those nuances. And certainly there's even more from the administration side of things that we have to pay attention to, or that are monitoring and things than what patients need to be aware of necessarily. But there's a lot, and again, I think it's going to just increase in complexity over the next several years. And we're really moving towards a quality-based payment system. And I think it's great if we have a lot of good outcomes for patients. We're improving the quality of healthcare that's being provided. We just need to make sure that we're still allocating enough resources so that providers and institutions can provide that care and can stay strong and meet the needs of the community. Are there questions? Yes.
I think it might be useful to discuss the doctor participation options that they have under Medicare, and to understand that when a doctor opts out of Medicare totally, your supplementary insurance does not kick in. They don't expect you shouldn't expect payment through that means. Another thing that I think you might want to discuss are the limits on doctors' charges for non-participating direct participation in Medicare. And also, if you would explain the criteria that hospitals are using to determine observational status versus admission.
Sure, those are all very good points and good questions. So the first issue is when physicians opt out of Medicare, any of the programs that follow Medicare rules won't pay either. So your Part A won't pay, your Part B won't pay, Medicare Advantage won't pay, Medicaid, none of them will pay because they normally follow those Medicare rules. So if the physician doesn't participate, you're right, you're going to be stuck with the expense. The patient would be stuck with the expense. I'm not sure if there is a cap on what those concierge physicians are allowed to charge. There are reasonable and customary standards that Medicare publishes for all other services, and they're geographically oriented. So if you want to see what would be reasonable for a certain type of service in Pennsylvania, for example, there's a higher rate that is charged for people who live in the greater Philadelphia region than the rest of the state. And that's how it is throughout the rest of the country as well. So there's different fee schedule. Most institutions, organizations charge those Medicare fees, or they go up by a certain percentage expecting that they're just going to get the Medicare fee, and then it's contract negotiated with any other insurance payer based on the Medicare fee schedule. The last question or point was about the observation status. So what the rule is, or the rule of thumb, I guess, is if you expect the patient to be in the hospital for more than 48 hours, then they're full admission. If you think that it's reasonable that they could get better in less than 48 hours, then it could be observation. So 48 hours is kind of your cutoff. We don't have the crystal ball, and you need to make the determination actually at the time of admission. So it can change. You can change on day 2, but you need to make the determination at the time of admission so that the order's written correctly. We have criteria. We have to, or things that they're looking for in our charts. We have to write the order correctly. We have to include our estimated length of stay. We have to include our treatment plan. And then we have to have in Pennsylvania, the notification for patients. And then the federal one will go for all states starting in January, the notification for patients for observation. Who started all of it?
It's new.
Observation status actually isn't new, but it's being utilized more heavily. And I think part of it being utilized more heavily is driven by, I think, the attempts to decrease waste. So there's a lot of auditing agencies that are contracted by Medicare and some of the other insurances too that look at our hospital stays, and they target anybody who's been in the hospital for 2 days or less, and they say that their treatment, they didn't require hospitalization for the treatment because they were only there for a short time and could have been observation. So, and then they'll take back the money retrospectively. If that happens, or retroactively, if that happens for anybody, if you're in the hospital, you pay all your bills, you do all your things, and then a year, 2 years, 3 years down the road, an auditing company comes back and looks at that hospital stay and either decides that it wasn't medically necessary for you to be in the hospital, or you didn't have as intensive a treatment as you needed, or something was missing in the documentation of the healthcare providers. They'll take the money back from the provider, and they could actually ask, like if the hospital billed the patient, them to recuperate that back to the patient as well. And sometimes you would get a letter talking about that. But they can look back like years.
This question relates not to the money part, but working with patients who have multiple problems, either as a provider or as a family member. Something that I would call medical problem overload. So, for instance, my mother was relatively healthy and then ended up with a few problems at once, which were addressed. And then her attitude was, I don't want any more problems. I don't want to see any other kind of doctor. And that's, I've observed that in a few other, with a few other friends and their family members. And I'm wondering if you come across those issues and how you address them.
Yeah, definitely. Especially as we're increasing the annual wellness visits and the preventative measures that are being done, we're finding more things in people who didn't have symptoms. So they may have felt well, they may have seen their doctor when they felt ill, but not on a regular basis necessarily, or maybe didn't have all the screening tests done because they weren't available, they weren't covered, and now they are. So we find more. But finding those things earlier, treating them earlier, leads to a better, improved longevity, better quality of life. So that's more of the approach I take. Like, we found this now when you feel good, but isn't it great that we found it so we can fix it before it's a big problem? It might mean that you have to take multiple medications now, but it's going to prevent you from feeling terrible in 6 months, a year, 2 years down the road.
Yeah, so I had a question. I know one of the things you talked about were some of the metrics for reimbursement according to Medicare. And I think, in general, everybody would agree that, we want the metrics to agree that we're providing good care and that outcome data is good. What are your thoughts on some of the metrics that are measuring patient satisfaction? Obviously, everyone wants their patients to be happy with the care, but I know a lot of the data is pointing to, if we're doing what our patients necessarily want us to do, that is not in their best interest.
So that's a complex question.
Yes.
There's HCAP scores is what it's called. So for patients who are in the hospital, a certain percentage of them get surveyed within 6 weeks of discharge from the hospital. The hospital has to provide a list of patients who are discharged to a third-party surveying company, which can be either done by paper or on the phone. So there's problems inherent in that. First of all, who's getting the survey? Sometimes my patients, I'm a geriatrician, sometimes my patients may not be the one responding to the survey. It might be somebody else in the household, and their experience matters as well. And but it still might not be what they're trying to capture, because when we're talking about, one of the questions is about quietness at night. Well, the family member may not know that if they weren't there at night. So how do they answer that question? So there's challenges there. There's also challenges in sometimes there's patients who have maybe reason that they want their pain. It's difficult to control pain in certain patients, and maybe there's some supratentorial reasons that contribute to that. So it makes it even more difficult to control that pain.
It's a very polite term. We like that.
Thank you. So when they're responding to the question about how well was your pain controlled, is the staff doing everything they can to help with your pain? Well, maybe the IV medication wasn't as high as they wanted it to be, or, we need to give our patients the appropriate expectations, though. If somebody's having surgery, they had their knee replaced, they're getting their bones sawed in half with a saw, it's going to hurt. It's going to hurt afterwards. So their pain level's not going to be a zero. So a lot of it's about, giving the patients the appropriate perception and expectation as well. We do all want our patients to be satisfied, but it is very difficult to take that information and make it useful when there's a lot of confounding variables. Yeah.
I had 2 comments. One, I read that under observation care, if the hospital sends you to a nursing home, you are responsible for those costs. They're not covered by any of your insurances. And second, I had with my father, where he needed to go into emergency room once a month for severe emphysema. They forced me to put him into a nursing home. Is that still being done?
So for the first comment about observation care, that is true. In order for you to qualify for skilled nursing care, that where the first 20 days are paid by Part A, you have to have 3 midnights in the hospital. And observation doesn't count towards those 3 midnights. So even if you're in the hospital under observation status for 3 midnights, it won't count. It has to be a full inpatient admission. Otherwise, Part A will not pay for any skilled care afterwards. So that is true, and that is a problem. The other comment about forcing people to go to aftercare facilities, I guess I don't know the individual circumstances, but I would hate to think that anyone is forced to do anything. It's really the patient, the family preferences. Are they able to meet the care needs of the patient at home?
I was caring for my father 7 days a week, but Medicare, through his doctor, said that they would no longer let him go into emergency once a month for a treatment, and I had to put him into a nursing facility.
So there is a lot of pressure on the doctors in particular, and it's coming from like the Medicare Advantage plans or the other insurance plans, because we're getting scored on the amount of ER visits we have because they want us to have longer hours and open access for patients who are sick. So we get pressured for that, and unfortunately, it sounds as though somebody may have translated that pressure to you. Something else that occurs anecdotally, not from what we do with our patients, but anecdotally from some of my patients or who've had family members or themselves in another facility, in looking at our outcome measures, those metrics, for mortality after discharge or readmissions after discharge, if the patient's discharged on hospice, they're excluded from those metrics. So some institutions are very, they're enrolling a lot of people into hospice on discharge.
Thank you for your conversation and information about the complexity of healthcare and particularly the payment of that. And just as a comment to your summary here about the fact that it's becoming more and more complex, I think as consumers of healthcare, there's a trend happening, particularly within the pay for performance that's occurring. There's a couple of other trends happening that I'm not sure that consumers are very aware of, and I'd like to hear you speak to that. One is that there are more and more practitioners who are not independent practitioners, but employees of healthcare systems. Therefore, there are being more and more pressure on these healthcare systems for these practitioners to meet these performance expectations. When that is not happening, these practitioners, there's a trend that's emerging now of practitioners firing their patients because they miss an appointment. Their patients' behaviors are affecting their ability to meet those pay for performance abilities, and what that might mean for the future in terms of access to healthcare.
Those are good considerations. A lot of the physicians, especially primary care physicians, are employed by health systems nowadays. It's very attractive to physicians. And part of that is because of the complexity of the payment system. To be able to navigate all of that or to have staff that's efficient and capable of doing that is challenging, and it's ever changing. To stay on top of all those changes is very challenging. So we rely on a system where there's experts able to do that. So that's one of the reasons a lot of people are employed. The employers do want us to have good scores because there's financial incentive associated with it. So there is pressure on the providers. I've had conversation in a group of primary care physicians with one of the big insurers in our region where that was asked. Are you suggesting if our patients refuse to have a colonoscopy and your threshold is 65% of patients need a colonoscopy, are you suggesting we fire that patient? And their answer was, of course not. That's why the number is 65%. Because there are patients who don't want it. There are patients who have other medical reasons why they can't have it. So I think no provider should ever fire a patient for those reasons. There are reasons that providers may want to fire patients, but not because we're not meeting the metric, because a patient is taking into consideration their own preferences, their own value system, their own culture in choosing a path for their medical care. Yes.
I've been involved in medical education and a faculty at a med school for over 50 years. One of the things that strikes me today particularly, and over several of the talks I've heard, is the lessening of the role of the primary caregiver, the physician, the APN, and the incredible growth in administration of policies by people who know less and less than the physician, guaranteeing more and more of the decisions that are made. And I think it's a broken healthcare system. We need to look at other healthcare systems and bring back the professionals into a more decisive role.
Thank you for your comments. If physicians traditionally are not very good at advocating and lobbying and doing those types of things. So when decisions are made, a lot of times the physician perspective or other provider perspective is not present because those decisions are made by people who don't directly provide the care that they're dictating. Yes.
Okay. I, too, am concerned about the ways that money is impacting healthcare. And I have a couple of brief questions, I think. One is, do you have any basis for comparing your experience delivering healthcare in for-profit as opposed to not-for-profit facilities?
I have very limited experience in a for-profit facility. The majority of my responsibilities have always been in a non-for-profit health system.
Okay. And my other question is these diagnosis-related groupings and capitated payment, what safeguards, if any, are there to make sure that in the name of so-called efficiency that we don't go below what is possible as a reasonable standard of care?
That's a good question. I don't know that I have the best answer. When we code charts and they're determining the DRG or the diagnosis-related group, all of the patient's medical comorbidities are coded as well, including procedures that are done. And if they have certain ones, then it increases the score. So there's like a little bit of an increased reimbursement for people with what's called a higher case mix index. But it's not exact, it's not precise, and it's we could certainly be missing. We could be going too low and then not providing institutions or providers with the funds they need to provide all the care that's required.
Hi, I've been involved with hospices since about 1978, when they were first just volunteer organizations. Today, the mean number of days is 17 in a hospice. And so, obviously it's really underutilized. I worked at a hospice where people died in the parking lot. So obviously they were getting a lot of futile care. And I'm wondering, I know one of the things that you said earlier was that doctors just hate to give that prognosis of 6 months or less. But for me, and having one parent who was in a hospice, who had grandkids in his bed, and we were all there when he died, and a mother who died in a hospital where we couldn't even see her. It's not about the doctor not giving the prognosis. It's about, for me, that's stealing time from a family if you're not really honest about the time frame, and you can be in hospice for more than 6 months. I mean, obviously we're not using it.
Right. And in my introduction, one of the things that he didn't mention is that I'm also board certified in hospice and palliative medicine. I'm a medical director of a hospice. I'm very supportive of hospice and the hospice and palliative approach to care for patients. I think that a lot of excellent care and excellent opportunity for patients and families is presented and underway in that setting. So I'm not speaking for myself, certainly, but I do have the experience, especially with oncologists, where I feel like patients come to me as their primary care physician asking me the prognosis when they've been seeing the oncologist and the oncologist doesn't tell them. So I think it's a problem in the medical community that we're not comfortable with that yet.
Right. Well, and I think the fact, too, as the woman said, people aren't spending enough time with their primary care physicians who know the family and know the values of that family. And it's one thing to say, if you take this chemo, you can have another 2 months. But they don't say you'll be flat on your back, throwing up, sick. And it's statistically proven that if you come into hospice, a lot of people, if they come in a time frame that's workable, you get better. Right.
And that's when hospice goes beyond 6 months, or they graduate from hospice and then use the service again in the future.
Mm-hmm. Thank you.